All right, pretend we never said anything about that.
No, it's good to memorize. Yeah. I don't know if we have to, but I think we need to put it in our brain so we understand it, so to help us with our work.
Right.
Is that maybe someone else could answer?
I've not been memorizing them.
Okay, good.
I'm not memorizing them either.
Okay, great. Thank you. Now I feel better. I just need to feel better.
Just for the record, I haven't either.
Oh, good.
Not
See,
really hoping that we don't have to. This, this professor is kind of, I don't even know what you're talking about. What are y'all talking about?
memorizing all the slides and the pictures
All
and
the-
everything that you
Yeah,
sent us.
pieces.
Oh wait, y'all are not memorizing them. Is that right?
I'm looking at them.
Oh,
Let's see. I'm gonna get everybody's name here. Let's see. All right, make sure.
They're very interesting. I put them on my desktop and I use them in answering questions and just trying to understand the material. I mean, some of it goes into my long-term memory. Hopefully more will eventually, but
Well, I can tell you, when you can't sleep at night, just pull out some of my PowerPoint slides or the DSM and just start reading them, and you will go to sleep very quickly. Okay. So at the very least, you'll know how to treat insomnia as a result of this class. Thank you all for your patience this last week. It was a week we had, and pretty sure my whole family, including myself, got COVID again, because it's either that or the flu. And even though my kids tested negative for the flu, they also tested negative for everything, but we all had fevers for like a week. Because my AC also went out.
oh,
And then we were informed, well, my postdoc was on vacation, and so she's like my surrogate frontal lobe at the practice these days. But then also Blue Cross kind of randomly denied about $6,000 or $7,000 worth of claims from that we were billing for, because I'm not on their panel, or they've taken me off their panel for reasons that they didn't inform me of. They just informed me by not paying. So yeah, it's been an interesting last week. So we're hoping this week it's already better, even though it's Monday. It's already better than what it was. Long story short, with insurance panels, is that when you get on insurance panels, there's another online platform that you have to put all your credentials in. Like, you have to update all your license information, your malpractice information, and then like literally every 45 days you have to reattest. So like you have to just re-up, make sure that everything looks good. If you miss that one time, apparently, because it's the first time in 10 years that I've missed it, you will be removed by the insurance panels that you were on and have to go through the complete process of reapplying, which sometimes can take months. And I've got patients booked out with Blue Cross for 6 months right now. And so I'm gonna have to inform all of them that I don't know when Blue Cross will have me back on their panel. So there you go.
there must be a recourse for you if you go to the city or wherever you practice and make a claim and tell them what happened. And you have to be able to, if you've been faithful for 10 years and putting in the information and then you just miss it, there's got to be a way around that. I would try. That's what I do for a living, stuff like that.
Well, I'm right there with you. Like, I'm usually the one that says, hey, you can eventually push far enough to get the answers that you're seeking. I can tell you that things have changed with Blue Cross such that I have yet to speak with an actual person despite calling all the numbers. And that's not for lack of effort. Like I've left voicemails. We've gotten email messages back, but I'm pretty sure ChatGPT generated them. And that's not how it used to be. It used to be that you could eventually call and talk to somebody. Our next step now is just to call like the customer line and just have whoever answers the phone send me to the provider, somebody to talk to at the provider level. But yeah, it's in their best interest to make it that way. It's cheaper.
I have the telephone number of the Anthem Blue Cross where you could call them and explain what happened.
Do you really?
It's 866-524-5659. And you just give them your identification and it might take a while for the rep to come on, but for $8,000, you ought to try it.
I will write that number down.
Yeah.
I'm not sure if so you said Anthem Blue Cross or Blue Cross Blue Shield of Texas.
Oh, Anthem. Oh, I'm sorry. Yeah, I thought you said Anthem. I'm sorry. Do you have Blue Cross Blue Shield Texas?
That's
okay.
So Anthem is usually out of California.
Well, no, actually we have it nationally.
Really?
But I don't have the one for Texas. Maybe I can find it for you if you don't have it.
I mean, I don't think I can legally give you extra bonus points for that, but
okay, what's the name of the insurance company? And
this is all recorded anyway, so I definitely can't.
oh, sorry.
Just kidding, guys. I wouldn't take a bribe like
Blue Cross Blue Shield
on video.
Blue Cross Blue
anyway.
Shield of Texas.
Yes.
Blue Cross Blue Shield of Texas. Okay, I can find a number for you to call, and I can just
appreciate
email
that
it.
so much.
I'll send it on the message line to you or something. Okay.
Well, I very much appreciate that. I used to know the person, and I've even presented on the top floor of Blue Cross Blue Shield Texas down there in Richardson, and their big office down there on all this stuff. But yeah, it's rough. So
it's terrible. It's terrible to deal with, and it's awful. So yeah, sometimes you need to just get some straight numbers. So anyway, hopefully
I would very much appreciate that. So along those lines, and it's not that we don't have other topics to also cover, but this is week 5, and I like to give space to folks to ask questions about private practice. If you're planning on going to private practice, all things related to private practice, what not to do in private practice, I especially know I can answer those things. But also practicum questions, internship questions, how do I specialize in things kinds of questions, licensure exam kind of questions. I want to give space tonight and week 10 for those kinds of questions, in addition to opening it up also to any questions that you might have related to any of the neurodevelopmental disorders, depression, schizophrenia, bipolar. And then also I want you to know we're not done with those topics, because I know we're missing 1 week. I'm going to try to find a makeup time for that week from last week as best as I can. But next week we will also be covering mood disorders and schizophrenia briefly, then also the anxiety and trauma stuff. Okay. So we will catch up. Thankfully, we are meeting weekly this go around. I used to just do once every 2 weeks, and that was just impossible, I promise. Yeah, with all that said, I want to open it up to any questions along any of those topics.
Can you just go back as far as you can remember and speak to me really slowly, like I know nothing other than I'm in these classes, and just go from there.
Hey, that's what is it on Reddit called explain it like I'm five, right? Yep. Those are my favorite, by the way. And it's never like an explanation as if you're five. It's always like an astrophysicist, like using all kinds of crazy jargon. Um, so can you be more specific? Because literally, if you leave it that open-ended for me, we will probably not wrap up until like 5 a.m.
So how does practicum work for Amberton students? Like you just go about, my understanding right now is you just go about finding a place for your practicum on your own.
Mm-hmm.
Okay. And then what? Then did somebody like observe me? Like what? I don't know anything.
Sure. Hey, that's okay. That's completely okay. And I'm sorry that I am genuinely sorry that you don't um, feel like you know anything and that you haven't been told more than what you know, because we are actively working on preventing that from happening, because we want students from day one knowing all of the stuff I'm about to tell you. So one is after your coursework, you've got two, if you're an LPC person, you've got two practicums during which time you have to acquire 300 total hours of experience. That's supervised experience, meaning that it can be you can in your practicum, which is different than your postmaster's internship. We're not talking about that yet for licensure. We're talking just to graduate, right? It's 300 hours of supervision, and that can be supervised by any master's level licensed mental health clinician or above. That's different than your postmaster's internship. That has to be by an LPCS. That's a licensed professional counselor with a supervision or supervisory credential. But your practicum before you graduate, that can just be any master's level licensed mental health clinician, including any LPC, any LCSW, any LMFT, any psychologist that's licensed, any psychiatrist, any psychiatric nurse practitioner. And so, in other words, you've got a wide range for what would technically qualify for a practicum and experience as it relates to who you can find to supervise that. Okay. A lot of students get hung up on trying to find an LPCS for practicum, and that's ideal, but if you can't, it's not the end of the world. And just so you know, and is it Jenny? Is that right? Am I saying that right? Awesome. And so just so you know, most programs, unless I would say most programs like Amberton don't have an embedded in practicum, such that like you have to find your own in practicum. That's even true for most psychology programs. So like psychology, we had to apply to a whole wide range of different internships across the US. But we had to do it ourselves and find them ourselves, which is different than med school, because med school is like they kind of just like push you into the next step almost for the most part until you have to apply for residency. But anyway, my point there is that for practicum, I would encourage you right now to start looking for a practicum site. So when you picture yourself becoming a counselor, like official one, I want you to think through like, what's my ideal place to get trained, and eventually, if it was the right place, to work. And then from there, draw a little 5-mile radius around your house, because I'm assuming you don't want to have to drive real far, and start researching what's the closest. And the sooner you can start doing that, the better, because you're going to find that there's probably quite a few opportunities around that may or may not fit what you want to end up doing, but at least you're going to get to know what's close. Then you just geographically expand from there, just Googling it really. And you're going to find that there's a lot of opportunities out there, especially with LPCSs, by the way. I mean, there's a lot more than what you think, where the further out you expand, the more likely you're going to find like the ideal like supervisor, the ideal setting of getting training. And then what actually happens in practicum, so you call, you'll call the place or whatever and say, hey, I'm an Amberton student. I've got practicum coming up in like 3 or 4 semesters. I've researched you online, and this is, I didn't see anything about, practicum, or I did or whatever. I would love to know if you have any opportunities for that. And if so, what can I do to prepare to become a good candidate for that position when the time comes? And then in most cases, if it's really the place that you want to be, they will respond nicely. They may say that they don't have anything, but at least they'll respond. If they don't respond, or if they don't respond nicely, you need to probably put a big X on that place, because unless you just want to be miserable for 2 semesters, I wouldn't go work there, especially for free, because you're not going to get paid in most cases. As far as what you actually do is going to depend on your level of experience and your supervisor's the opportunities that your supervisor can provide. So whenever I've had a couple practicum students from Amberton at my practice, where basically from almost day one for both of them, because of where they were in their training and their experience, I was comfortable with them taking on a couple of real straightforward counseling cases where I wasn't in the room, but I was supervising them directly along the way. Now, I didn't throw 15 cases at them, and we screened it all of them to make sure that they weren't diving headfirst into like a substance use disorder, or like a personality disorder or something like that, or something legal especially. But that's going to range depending on who the supervisor is, their style of supervision, to where out of those 300 hours, you're supposed to have, I think it's 150 face-to-face direct hours. In other words, either observing like counseling happening, or providing counseling, or doing like an intake over the phone, in my opinion, would count as face-to-face direct contact. And then the other 150 hours is like writing progress notes and doing the administrative stuff that kind of come along, and trainings and things like that. And then at the end of all that, your supervisor signs off and says, yep, they did all this stuff. It's like one form. Then you graduate. That's pretty much it.
Thank you.
Does that help?
Sure. Yes.
Awesome. And again, the earlier the better you can start looking. Don't wait until like your pre-prac. A lot of students are like, well, I'll just wait till pre-prac to find a practicum. Well, guess what? Everybody in their pre-prac has waited till their pre-prac to find a practicum. So y'all end up all calling the same places. So the sooner the better. Just go ahead and like find the most ideal place. Be like, I want to be a millionaire in a counseling practice. So I'm going to find like the most, lucrative practice or whatever it is with the best training. And, it's a year ahead of time, but I'm going to get my name in there to be competitive. The good news is that if you find an LPCS, in most cases, they're going to charge you for their supervision, by the way. That's why there isn't such thing as an LPCS. That's the incentive, is that they can, once you become an LPCS, you can officially add that to your revenue stream in your practice by taking on practicum students and making them pay money for your supervision. Usually that costs the same as their typical hourly rate would be, a lot of times they'll have multiple practicum students where they'll do like a group supervision, and you can split that cost up over, 3 or 4 different prac students. So instead of 150 an hour, it might be like, $40 an hour per person. Yeah. Good news about that, even though it's not really good news that you have to pay money, is that you also have like a lot more power in that situation. In other words, if you don't like that supervisor, I mean, you're not stuck with them. You can fire them. Nobody's going to make you continue to pay somebody that's terrible. Okay. Unlike psychologists, literally, like, yeah, we just kind of got what we got, and just be glad that you got what you got. And that was rough. I had a rough year working 90 hours a week, my internship. Would not recommend that. So you don't have to do that, but whatever theory you are, if it's, play therapy, existential therapy, CBT, EMDR, whatever it is, moonwalk therapy, start researching and try to find people who are the supervisors who have a great practice, or if that's where you want to end up, that also offer that training. And ideally, if you work out, a lot of those places will hire you on to join the practice after all's said and done, or at least offer you an internship, which is after you graduate. That's the 3,000 hours you gotta do once you're an LPCA. Yep.
Thank you.
You're welcome.
Can I shift to a psychopathology question?
Oh, absolutely.
Would you speak to your experience with abnormal motor behaviors that you've seen in psychosis? I actually once witnessed a patient who I knew before and I saw during this psychotic break. And it was one of the scariest things I've ever seen in my whole life. And I just wondered if you could give some normalcy to that experience for me, and help me understand and help the class understand what's happening here. And I mean, basically, what can you tell me about that?
Sure.
It was
So there's 2 types of behaviors or repetitive motor behaviors that you will see with psychosis. One is directly caused by the psychosis sometimes. In other words, part of the actual pathophysiology that causes the psychosis in the brain to begin with also can cause abnormal motor movements or repetitive motor movements, especially. Then there's also the side effects that can sometimes occur from the antipsychotic medication that people take for the treatment of psychosis. And those are called extrapyramidal side effects, EPS. I'll put that in the chat there in case you want to name your dog that someday. Extra side effects. It's called EPS.
I had to take this patient to the emergency room because I found her in this state. So she hadn't had any antipsychotic medications yet. And I watched her go through this and then had to get her admitted and take care of her health, kind of manage her health care. And so I'm thinking it didn't have to do with the side effects of the antipsychotics because she wasn't on it yet.
Right.
And so I just wondered but she had been using benzodiazepines and alcohol for a while, I found out. So that could have had something to do with it. But I
Well,
just,
if she were withdrawing from that at all, she would have developed delirium tremens, DTs, which looks like Parkinson's almost, like with a tremor. And so I'm not sure if that's what you observed or if that's what you're talking about, but knowing that information by itself, I would know that if we were in withdrawal, we would definitely have an ataxic looking gait. We would have what would look like essential tremor, even of the neck and upper torso, upper extremities, but especially with the hands, and even the voice can be shaky. And then, in addition to that, gosh, what I was going to say was, oh gosh, what was it?
what about like facial changes and stuff? Like her face is doing something I've never seen before, if you know what I
Right.
mean. Really
So-
scary.
Sure. So those that can be a tremor, first of all. It's called a lip smacking tremor. But I'll be honest with you, I've seen that more commonly with Huntington's disease, the onset of the psychosis with Huntington's versus schizophrenia. And so when you say that, unless there's like some sort of other substance abuse, like a stimulant and a withdrawal from a stimulant, because that's usually what ends up causing that, like the dopamine depletion, the dopamine burnout from like meth. When they get off of meth, when they get off of, crack cocaine, things like that, you'll see the lip smacking tremor a lot of times. Gosh, and there's even a more technical term for it, and I can't remember exactly what it is. But going back to the psychosis piece, it'll help you understand why you can have repetitive anything, even psychosis, like psychotic thoughts or hallucinations or hearing voices, when you understand that psychosis is a disinhibition of the frontal lobe, which is the filter of intrusive thoughts. All of us on the planet have intrusive thoughts. All of us on the planet are hearing voices. All of us on the planet have delusions. All of us on the planet have paranoia. We all have we all have compulsive motor movements that we are wanting to do, or even repetitive motor movements that we're wanting to do, like Tourette's and tics, for example. Every single person has those impulses happening. The difference is that psychosis is the result of that brake pedal or the filter for all those things not working as well as it used to. Which is why everybody with psychosis will develop in some form or fashion, alongside the psychotic symptoms, OCD symptoms. And for that same reason, you can think of Tourette's and tics, like the repetitive motor movements with that. Those are just motor movements, whereas they're like the intrusive. They're like intrusive motor movements. Instead of intrusive thoughts, they're intrusive motor movements. That's the best way to describe it.
So that can cause whatever causes that disruption in the frontal lobe can cause a person to do things and act in a way that it looked like she had no control over, you know what I mean? It's like she'd lost complete control. It's really
like whole body movements, like whole body movements, or just
like kind of like falling on the floor and making these strange faces. And it was I'd never seen anything like it in all my years in nursing. Never seen it.
So
and I just wondered kind of what, so maybe it's the the loss of the ability in the frontal lobe to filter those intrusive things that were coming in, and she just gave into it, I guess. And
Well,
maybe I was the lucky one that got to see it.
And I
don't know.
remember now what I was going to say was I have seen that. Well, what all that reminded me of, Olga, when you're talking about that, was seizures. So people coming off of benzos and alcohol can often have seizures, and in fact, they can be deadly, which is why withdrawal from that stuff is
Okay, that's very helpful then. That maybe that was what was happening.
And seizures generally with the withdrawal from benzos and alcohol, those types of seizures are generally generalized enough that they will impair motor functioning, but a lot of times you don't get the grand mal seizure where we're losing consciousness as much as you're getting limbic and frontal lobe seizures, which I'm here to tell you, if you've ever seen a limbic seizure, it looks like an explosive anger episode and or like hypersexuality with all kinds of inappropriate behavior. In little kids, you can actually have like they will start humping things. Like I've seen all that before.
Yeah, she was just doing things that were like bizarre, and I'd never seen, and I had known her before, so I knew she wasn't like that. And I watched her become, and it was just like a completely different person. And so I wondered if that's what you see that very often. You know, it's
I've
really troubling.
When I've seen that, like, so there's two things I always think of is because that's not a typical psychotic symptom, by the way.
Oh.
Like in a psychotic break. I mean, that's not that's above and beyond like a schizophrenia psychosis.
Okay.
You're more likely to see that with a psychosis secondary to delirium.
I actually wrote that in my notes because I was going to ask you, could that possibly be connected? Yeah.
Yep. Medical, usually like liver problems or like kidney failure or diabetic ketoacidosis can look like that a lot of times too. And then, but also you can have a background psychosis happening or even emerge during the same time as something else is causing the seizure. So a lot of times, in other words, people with psychosis will abuse alcohol and benzos because of their anxieties being so high. And it's like the only thing that can make them not feel as anxious or paranoid all the time.
Okay.
Yeah.
Thank you for addressing that. I know it's kind of a personal case, but I always I had to turn her over to some other medical people, but I never could. I always wanted to find out what happened there, and so thank you for that. I appreciate it.
When I worked inpatient, mostly it was paramount that we had a really great psychiatrist who would say, listen, we don't know it's mental health until we have looked at the whole picture, especially with the adults onset kind of psychosis like that, where it's, not 18, 19, 20, but they're like 35 or 40 for the first time. They're going to do all the scans in the world of the brain, EEGs, get their blood labs, all that stuff before we land on schizophrenia. Yeah. But that's not how everybody operates. A lot of times they'll see psychosis and they'll get prescribed, Geodon or some harder antipsychotic at least. And then because of that prescription, they'll have a unspecified psychotic disorder, which they'll carry the rest of their life or whatever. But because that antipsychotic is going to treat psychosis no matter what's causing it. Just FYI.
That's a really big piece of news. Is that right? So the Geodon will, no matter what's causing it, it will be effective. That's
I mean, not just Geodon, but usually it's in the short term, a whole bunch of Seroquel make them sleep.
Okay.
Or quetiapine is another word for that. You'll see Zyprexas. You'll see oh gosh, what's the other one? My brain's going blank right now. The second generation antipsychotics, but then sometimes you'll even see like clozapine, which is second generation, but you'll see Thorazine even, which is the old school one.
Oh, old school, yeah.
Yep,
So
yep.
that-
First generation.
Yeah.
But they'll do that acutely just because they're so agitated. But if you remember right, antipsychotics, by the way, just so y'all know, when you hear the word antipsychotic, also think tranquilizer, because that's the same class of medication. Okay. Also think sedative, because it's the same class of medication. So when people say like, oh, you know, that was a horse tranquilizer, well, guess what it was? It was an antipsychotic. Usually it's like risperidone or what's the other one? Or clozapine. I mean, that's a good one, honestly. So, but that's a great question because guess what? You read all this stuff in the DSM-5, right? And you're like, okay, I think I got Latuda. Yep, yep, yep. What is that? Lorazepam? I think that's what the generic is for that. Yeah. And Vega being another one. Gosh, there's so many of them. Abilify. With so I don't want to scare you, all right? But I'm glad we brought that case up because, folks, that's probably going to be like the first case that you see out of in practicum. I don't mean to make you nervous. You're like, oh, great, what am I doing? I just remember, at least in my experience, I've seen it's like, I don't know what I'm doing. I'm a brand new therapist, and then all right, I'm gonna take on this one client. I was just depression. I'm gonna work just depression, and they come in and they're like actively psychotic and suicidal. It's like, and on all the drugs, and they're going to court next week. Just prepare. Don't be surprised if that happens. It's not the universe trying to tell you that you shouldn't be a therapist. Okay. And also know that you are smart enough to handle it. Because if you don't know exactly what to do, at least you know how to be a kind human being. And at least you can be humble enough to say, well, I don't know what to do. I'm going to talk to my supervisor and I'm going to do a whole bunch of research on Google, figure this stuff out. Because that's what almost everybody else did, I promise. And you're smart enough. When you do your research, you're probably going to know more than what people would even recommend that you do, because there's more forums and all kinds of stuff online that you can find. So it's okay to feel anxious completely if you get that case right out the gate. But don't worry, you can handle it. I promise. Okay. I only say that because I had my first patient had schizoaffective disorder and was actively psychotic. My very first patient, practicum 101. My supervisor was out of town. They talked to me beforehand. They're like, I think this is just like social anxiety. I think you'll be okay. But I'll be back on Monday. We can talk about it. It was like a Friday evening. Schizoaffective disorder. This person drove themselves up there and they were actively psychotic. Did not know what to do. I literally, pretty sure I didn't say anything for like 30 minutes. My eyes were just real big. The whole time I was like, I'm quitting counseling after this. This is my last counseling session ever. Yep. Other questions?
So what'd you do?
Just leave you hanging. I asked the person kindly if they wouldn't mind me getting a drink of water and using the restroom real quick. And because I didn't want to be like, actually, I don't really know what I'm doing. So can I call somebody? Which I wasn't lying. I did use the restroom almost gonna say almost in my pants because I was that nervous. But I went and called the site like director, like the admin person, who then connected me with like the backup supervisor, and who then begrudgingly dropped what they were doing there in the middle of like a dinner or something and came up there to assess this person. They ended up having to get a 72-hour hold because they were psychotic. We had to help them find, first of all, I had to communicate that to them with my supervisor. I mean, I didn't. I was just sitting there the whole time. I felt terrible because I felt like I was causing them to have to be hospitalized. But the truth is that had we not done that, there's a good chance that they would have hurt themselves or hurt somebody else, not intentionally, but just because of where they were, because they had stopped taking their medication. That's what it was too. And if you've never seen manic psychosis, let's just say that you will know it when you see it because you can't make it up. You can't fake it. I mean, you can pretend to, but it's like riding. It's like you remember those. I don't know if you ever went to carnivals, because I'm from Paris, Texas. We went to carnivals like in the Marabou Square, like the little outdoor shopping area. There's a little zipper ride that was probably not safe, but you will start to cognitively feel like you're just going 7 different directions while you're conversing with folks who have active psychosis and mania, and you're not able to stay on track. And you're going to first feel like, what's wrong with me? Am I not paying attention? But then you're going to realize that you've had some loose associations there and you've jumped track mid-sentence, and you're going to be asking a lot like, wait, what did you say again? Can you say that again? A lot. Yeah. When that happens, here's the thing. If I can help you empathize with that stuff and not feel so afraid of it, if you encounter somebody, let's say that's 25, having those kinds of symptoms, I want you to imagine that they are grandma with Alzheimer's. And I say that because it's a lot easier in general to empathize with grandma who has Alzheimer's, having a psychotic episode or psychotic break and not understanding where they are, when they are, things like that, right? Because you conceptualize that as neurological and that they need help, correct? When you see like a 25-year-old, 6'4", like person, grown man, or somebody that looks like a college student that maybe looks like they did some drugs or something, having the same symptoms, imagine them as grandma with Alzheimer's, and it'll help you understand what you need to do, because it's just as neurological. In fact, the same reason why grandma has psychosis, it's the same pathophysiology that caused psychosis and schizophrenia. The difference being is that one comes with a progressive form of cognitive decline. The other one happens to be just primarily like the psychotic symptoms. Although, truth be told, schizophrenia was initially called dementia praecox, which means precocious dementia, because there is a cognitive decline that occurs after the first psychotic break. You can measure that with the neuropsych test that I do. So if somebody was an average IQ before, after the psychotic break, they might be like low average. And the question was, is the psychosis and dementia linked to sundowning? Absolutely. And sundowning occurs 2 times during life, by the way. During the terrible 2s, 3s, and 4s, and sometimes 5s. If you ever think about kids during that time, if you aren't familiar with that, I would invite you to come to my house around 5 p.m. if you'd like to see it firsthand. Sundowning occurs with kiddos especially younger kiddos, because what's happening is there's a transition of daylight, which literally triggers like the melatonin like production cycle in the brain, which is right next to the serotonin cycle or the serotonin like system, or the limbic lobe is another way of saying that, the emotional processing center, through the hypothalamus, suprachiasmatic nucleus, if you really want to go that far. And then what happens with sundowning with kiddos is that you've got this brain that is developing those connections. And so it's more plastic, but for growth reasons. Whereas with dementia, and to be honest with you, just if you get old enough, it'll happen too. With dementia, you have a disease process or a degrading of those connections in the same areas of the brain that subsequently interfere with serotonin, all those things, where you end up getting the same kinds of symptoms of psychosis, or not psychosis necessarily, sometimes psychosis, but it's agitation, it's revved upness, sometimes it's even paranoia, but you'll see that even with little kids. Little kids will start having intrusive thoughts around that time. They can't sleep. They'll start, I mean, if you get them tired enough, I promise you, they will hallucinate. Yep. But the psychosis with dementia, with sundowning, happens particularly at sundowning because of the transition from daytime to nighttime, how that incoming light, like just it's called a zeitgeist, changes it's like a light switch that, I mean, kind of like a light switch that turns on different neurotransmitter systems, which in turn unleashes the psychosis. Or just real quick, so sundowning you'll see more often with Alzheimer's and Lewy body dementia, much more so than anything else. Those are the two that you'll see sundowning occur the most, compared to vascular dementia, Parkinson's dementia, frontal temporal dementia. Those don't have it as often, just FYI.
Do you think this is the first time I'm hearing about sundowning, and my kids are all of these ages, by the way.
Okay.
And I'm curious, I think it was like the first class we talked about night owls and this large portion of the population. Do you think that like if some of my children are like more of the, like if they're that part of the population, that they'll experience this more?
Yes.
Is that your experience with your children? Got some special ones?
Yep. So that's anecdotal. I'm glad you asked that, because I've thought that before too, with not just sundowning, but also paradoxical reactions to like antihistamines, like Benadryl, for example. That same 1/3 of the population, usually instead of like getting like sedated, those kiddos will get like revved up. Instead of like, getting tired with like, usually melatonin doesn't work as well. But also, anyway, my point there is, yes, it seems to be that transition is harder for those of us in that 1/3 of that category. And it's like, and it makes sense too, because that 1/3 of the world population there has a different monoamine neurotransmitter. It's going to sound like a big old word, dynamicity, meaning there's wider range of how quick our brains respond to environmental input. And when I say respond, adjust to environmental changes, such that whereas the other 2/3 of the world population, there's a quick, upregulation and downregulation of like serotonin, dopamine, norepinephrine. For us, our brains lag behind. So in other words, another good way of looking at this is the same reason why women with ADHD almost always have PMDD, is because their brains don't adjust as swiftly to that drop in estrogen. as everybody else's. And when estrogen drops, so does dopamine, norepinephrine, and serotonin. So that happens for the same reason that kids are going to have more difficulty with those transitions, going to bed and waking up, slow to wake up, like not morning people, or they wake up too early. It's like they wake up at 3 and then they're up for the rest of the day. It's like there's always like this moving target. But I'm not sure if they answered your question, but I think I could have just said yes and it would have answered your question.
It was a great answer.
Okay.
Glad
Well,
to know another parent of young children.
every time I end up rambling like that, I always think of my old supervisor, Dr. Gary Mears, bless his heart, because that dude is my dissertation committee chair. I'd go in there, I'd literally just have like one question, like a quick question, like, what was the name of the person that I needed to cite, for this paper or whatever. And I'd say that, and then like 7 hours later, I'd leave there not knowing the name of the person I needed to cite, but I'd know everything there was to know about that, what they wrote about. And they told me like everything else. And I'd leave there and be like, I'm glad I asked the question, but good grief, I don't want to have to go back in there and ask him again. And I'd email him and he'd never email me back. So I'm like, I am becoming this guy. Slowly. Yeah. We've got just a few more minutes here and just wanted to give everybody space to ask questions. These are great questions. See how these questions help? Like, I didn't have that stuff planned. Like when you have those questions, that's what helps me just go off on my tangents. Sometimes those tangents are helpful. I need an outlet, people. This is my outlet, okay? So I need y'all to ask questions. It's either y'all or the wall. I'm going to talk to you about this stuff. So please let me talk to people. I think I'm kidding. I've woken up sleep talking about psychology before. That's the nerdiest thing ever, by the way.
I have a comment. It's not really a question. It's just a comment. It's just I
Sure.
just want to share this. A friend of mine called me last weekend, and her brother was going through. It was going through dementia, and I say was because, excuse me, he passed away this morning. But when I take the quizzes, I always go in the first time and just go by what I know.
Sure.
And I didn't do well on the quiz.
Sure.
And in between time, I was about to go back and like look over to find the answer. Well, she called me and I was like, you know what? I need a break. Well, in our conversation, I kid you not, she gave me every answer to the quiz.
Oh wow.
But I didn't ask her any of the questions. She was telling me about her brother.
Interesting.
And everything she said was one of the questions. And I just thought, wow. I wish she would have called me. I wish she would have called me before. And then I wouldn't have to take that quiz.
Well, I'm sorry to hear about him passing away, but I'm glad to hear also though that the questions aligned with real world stuff there.
Yes, I just thought that was just something. In fact, I was kind of telling her, I was like, oh my God, you just gave me all of the answers to this quiz. Well, but like you said, I was really sad because we grew up together and she didn't even know her brother was suffering. His wife just told the family. Gosh. So she came down to visit and,
Well, I can tell you is dementia it's a hard battle, but well, just so you know, so part of my job as a neuropsychologist, whenever I do dementia evaluations, oftentimes I'm the very first clinician to give the message that, hey, you have Alzheimer's, or hey, your wife or partner or your spouse or your dad has whatever, Alzheimer's or whatever. And I can tell you is that our thoughts about what it is, I'm not to dismiss how hard it is, but it's a lot scarier of a word in our mind than what it has to be, because if we catch this thing, at least, well, you're almost always going to catch it like in the earlier stages. When that happens, as a counselor, you have an opportunity to help somebody kind of wrestle through some big existential kinds of questions, especially like spouses and things like that, to help kind of identify like, hey, listen, and this is, it's not what I always say, but this is kind of the concept that I pass along, is we all have existential dementia. In other words, we are all, if we're adults, we are all on the decline. And guess what? That decline is going to lead to death for all of us. Now, I'm not here to say that that takes away from the gravity of being diagnosed with dementia, but we're just confronting something that always was going to be anyway. If that makes sense. We're just acknowledging it now.
Mm-hmm.
Now that we've acknowledged it, now what that means is we get an opportunity as much as we can to live the rest of our life with our priorities in the way that we wish we always would have had them. Because now we know our time's limited officially. We're finally acknowledging that. And if we catch it early enough, we can take away the stress and the pain that our family will experience, or the grief that they will have to endure, by preparing ahead of time while we still can, for how will we know when I need to give up my car keys? How will we know when somebody else needs to take over my finances? Who's going to do that? So we can kind of start getting those things in order in a way that isn't as stressful whenever I don't remember why you're taking my keys away.
Mm.
And then on top of that, we've got some time, a lot of times, with our spouse or our family to really grieve with them and process with them, like all the good stuff too. All the stuff that you wish on your deathbed that you'd be like, I really wish I would have said, hey, son, I'm really proud of you. Now we get an opportunity to do that intentionally, so that when we get there, and we were always going to get there, we're not going to have that regret. That's the power of doing therapy with people with dementia, by the way. Because you're going to see them not at the moderate late stage, because at that point, they're not going to benefit from weekly therapy in the same way that everybody else would. They still benefit, by the way, just an FYI. Their brain doesn't consciously remember that they met with you last week, but their right, I'm saying their left brain doesn't, but their right brain does. Their implicit memory does. There's actually improvement of their mood when you do supportive psychotherapy with people who don't remember that they're even in therapy. Isn't that cool?
Well,
That's pretty cool.
Yeah. So literally, you don't even have to know what you're doing. You can just meet with them, talk with them, be present with them, and it will help their brain and help them regulate their emotions better. Promise. Yes, Shannon.
I have a question. On my late husband's side of the family, his mom had Parkinson's and ended up with dementia and hallucinations, which were funny. She would be on the phone and say, "I have to go. Chip is running down the hall," and that's my husband. She would think he was running down the hall, and she had to go catch him. But
That's
her
Louis body, by the way.
okay, I was wondering if, because you said Lewy body and Parkinson's were maybe different, but yeah, she would hallucinate. But her brother also then had MSA.
Multiple
and
system atrophy.
yes. And
Mhm.
so they both died within like a year of each other, and he was like 14 years younger.
Mm.
So I wonder about that, like for my children, like, that was their grandmother, their
Mhm.
great uncle. My husband died suddenly of COVID, so
Mm.
we don't know what would happen with him. But what is their likelihood of having something like
Having
that?
those. So as far as we can understand is that the genetic contribution to Parkinson's and Parkinson's plus syndromes
Mm-hmm.
Aren't as great as the environmental factors are. So like, in other words, the prevalence rate for a lot of this stuff is going down over time.
Ah,
Not drastically, but it is going down. And at least the running theory is the well, I'll just be honest with you, the prevalence rate for Parkinson's and Parkinson's plus syndromes is significantly higher for those who grew up in rural areas with well water and or around agriculture, and exposure to all kinds of like pesticides and things like that. And I can tell you, a lot of welders will end up with Parkinson's for like, because they accumulate like manganese in the brain, and your
okay.
brain can accumulate stuff like that, where people in the rural areas, especially back in the day,
Mm-hmm.
were exposed to a lot of stuff like that, that, as it turns out, will end up causing Parkinson's and Parkinson's plus like syndromes.
Oh, that's very interesting. Yeah. Okay. Yeah, they did grow up in rural Mississippi. So
Yeah, yeah.
that's
And
very
so, but with all that said, sometimes Parkinson's, like with Michael J. Fox, for example, sometimes it is
Mhm.
like almost a purely genetic kind of syndrome. It's almost like Parkinson's is a syndrome that can have many different causes. Most often, it's going to be like exposure to environmental things combined with the right genetic predisposition.
okay. But like a gene triggering, is it? You think it like triggers genes, like they say?
Yep.
Mhm.
And I personally think that if you're in the 1/3 of the world population there with the ADHD, autism, all that stuff risk, that Parkinson's is probably also on that list as well.
Okay.
As far as the risk goes, doesn't mean everybody develops it. It's just that
Yeah.
we know that when you look back in those folks' lives, a
Mhm.
lot of people had ADHD like symptoms. A lot of people would have had bipolar like syndromes, and especially
Mhm.
autism. Autism tends to be much more prevalent with Parkinson's, Parkinson's plus, and Lewy body stuff. Yep.
Oh, that's interesting. Now well, you don't want to go into my whole family history, but that's interesting. Thank you. Thank you for
Sure. Absolutely. Yeah. Sure. And I'm sorry to hear about your husband and
thank you.
your other family. Yeah.
Yeah, thank you.
Um, well, it's 9:34. I'm impressed with you guys. If I could give you I'm gonna give you 5 life bonus points for making it this far. I don't know where you can spend those. Probably not in this class, but just in life in general. Next time you get pulled over by a cop, tell them, say, hey, listen, I got 5 life bonus points. All right. Just tell them that. I appreciate y'all's patience and
Yeah,
your
I'm a
time.
cop, Dr. Levi, and I got a ticket anyway. I mean, I got it dismissed, but they gave me a ticket.
So
But that's just the town that I live in.
you are do you live in East Texas by any chance?
I do. I live in Greenville.
Yes, I knew it. I'm from Paris, and I could recognize your accent, by the way.
I actually went to police academy in Paris.
Did you really?
East Texas Police Academy out of Kilgore, but
Yep.
we had classes in Paris, Texas.
So I used to do all the L3 evaluations for them, by the way. All
You
your
probably did. You probably did my son.
possibly I did a whole
Because
bunch
he
of them.
said the psychologist was funny.
Hey, all right. Well, it definitely. Well, I'm telling you, there's like 2 funny psychologists out there. The rest of them were not funny. All right. But I appreciate that compliment. Man, that made my whole week just then. And yeah, just randomly, I know it's got nothing to do with anything else, but my wife is looking at becoming a police officer. She might be applying for Plano. Yeah. So
Good for her. If
Yeah.
she need me, I got 33 years in, and I
Oh.
did used to teach police academy.
I might reach out to you and see if she can talk to you a little bit about it, because
That'd be fine.
I think she'd be great at it. she's a great mom, and I think that's probably harder in some ways.
Mhm.
Yeah.
It's hard on the kids. That's my boys.
Right.
In fact, I
Um,
pulled one of them over when I was on the streets. I'm in the DA office now. Thank you,
Awesome.
Jesus.
well, hey, folks, I appreciate y'all's time. And if there's anything I can do in the meantime, please let me know. But we'll plan on next week. Sound good?
Okay. Yeah.
Absolutely. Y'all have a great night.
Thank you, Dr. Armstrong,
Good night.
All right. Good
so
night.
much. Bye-bye.